All right. Good morning. My name is Ryan Hakimi. I'm a neurointensivist at the University of South Carolina in Greenville, South Carolina. I'm also the medical director of the Neuro ICU at Prisma Health, which is the affiliated teaching hospital for the University of South Carolina. This morning, we're going to be speaking about an introduction to TCD in neurocritical care. So to begin with, I have some disclosures. Many of these slides have been adapted from slides presented at the American Society of Neuroimaging annual meeting by my mentors, which are pictured here. I serve as the treasurer for the American Society of Neuroimaging. The objectives of our discussion today are to review the basic principles of transcranial Doppler ultrasound, to describe the diagnostic evaluation of vasospasm, to detail the current levels of evidence supporting the use of TCD, review the literature with regards to subarachnoid hemorrhage, and demonstrate the use of TCD as an ancillary test for brain death, as well as a brief discussion about PFO, and discuss the use of TCD in carotid occlusive disease with a case at the end. So transcranial Doppler ultrasound is an imaging modality which uses various windows. They're called acoustic windows, one of which is the temporal window pictured here, and that is the probe is placed on the temporal bone, which is right above our the tragus of our ear. There's an indentation there, and the probe is placed perpendicular to the brain. And in that case, the middle cerebral artery, which is sending blood towards the surface of the brain, you can picture it as if you form an L with your other finger, and you put the probe on one side, the middle cerebral artery would be represented by your thumb, and the anterior cerebral artery would be represented by your index finger. And so here in the image, the blood is flowing towards the probe here, and that generates a positive deflection on the spectra. In contrast, the anterior cerebral artery is flowing away from the probe, and that would be projected below the baseline, not shown in this image. You measure certain TCD parameters, which are then used to perform calculations by which you can then make your clinical decision making. So here, the most common one is the mean flow velocity, whose calculation is listed here. And that has been what's been validated in for TCD. In contrast, for example, many of you may be familiar with carotid vascular imaging. In carotid imaging, it's the peak systolic velocity that has been validated, not the mean. So it's always important to remember to look at the mean flow velocity when we're talking about TCD. So here's a busy slide, but if we deconstruct this slide, we can then determine how these values are calculated. So let's start with this portion of the waveform. So here you have systole, and there's rapid systolic upstroke, and this is the peak systolic velocity here is represented by that. And if you sort of go across, you see that it's somewhere in the neighborhood of 90 centimeters per second. And then you have the initiation of diastole, which is this downward slope here, and that's the dicrotic notch, and there's your end diastolic velocity. Important to note in this slide is that the brain has perfusion, meaning blood flow to the brain at all times. And so that is represented by this portion of the spectra. So no matter whether you're, what portion of the cardiac cycle you're in, there is cerebral blood flow to the brain as represented by here. In contrast, if you were to look at a radial artery waveform, such as an arc line, you would recognize that the diastolic flow, meaning at the end of diastole, it's very close to zero in the baseline. And that's because the oxygen dependence of your hand is quite different than that of your brain. In addition, from here, you'll see other parameters such as the pulsatility index and other features. So here's a breakdown of that particular waveform. And so again, systole, there's a peak systolic velocity. Diastole, here's your dicrotic notch, and there's the end diastolic velocity. And so we use this formula which is technically called Gosling's Pulsatility Index, but most of us just simply refer to it as PI, and is the peak systolic velocity minus the diastolic velocity divided by the mean. The line doesn't project there very well. And some folks, particularly in Europe, will also, in addition, calculate this, which is called the resistivity index, Porcello's resistivity index, and that's less commonly used in the United States. So what is the clinical meaning of PI, and how does it impact our patient care? So in general, 0.6 to 1.2 is the normal range of PI for the middle cerebral artery. See, you have peak systolic velocity, and you have the end diastolic velocity here, and it's perfusing the brain quite well here because the end diastolic velocity, which is represented from this point to this point, is quite high. It's about half of the waveform. Now, in general, as we age, our vasculature becomes more firm, and our brain compliance decreases as well. And so this would be somebody who is much older. This could be in the normal population, 1.2 to 1.6. It just simply would be an elderly person who, over the course of time, has accumulated some intracranial atherosclerotic disease. Similarly, anything that makes the resistance, the compliance of the brain lower will also result in an increase in pulsatility index. So, for example, if this individual here had a subarachnoid hemorrhage and has obstructive hydrocephalus, their waveform morphology would change to this, and the PI would go up. As you can see here, a very common cause of elevated PI is increased ICP. And as you further go down, you see that the diastolic blood flow is impacted, and this is how many times when we talk about cerebral perfusion pressure, we all know that that is the MAP minus the ICP. This is a pictographic way of looking at that because the diastolic component is reduced, so therefore the cerebral perfusion is reduced, and it's primarily because in this example the patient has increased ICP. And then this is a severe example where there's no cerebral blood flow in diastole, so the brain is completely dependent on the cardiac cycle to send any blood flow up. There's no consistent blood flow in diastole. At the other end of the spectrum, when you sort of see this amorphous looking waveform, that's something to think about an arteriovenous malformation, because that's a venous looking tracing. And so if you obtain that within the brain, the first thing you should think of is an AVM. When we talk about insulating the brain, that's the term that we use for taking our measurements. We have three primary windows that we look at. Again, the transtemporal approach right here over the tragus, the suboccipital, which is if we palpate on the back of our head, the occipital protuberance, and it's projected upward and anterior, because we know that the vertebral arteries are sort of like an upside down Y, and the basilar artery is projecting from that, and so you image from the back in an upward fashion. And then we have the transorbital approach here, which we look at the ophthalmic artery, which is exiting off of the carotid and coming out. So those are the three windows that we look at. Here's the CPT codes for those of you interested in starting your own laboratory and wondering how to bill for this. So with regards to subarachnoid hemorrhage, this is the most common utilization for neurointensivists at this time. So our clinical exam is not as valuable necessarily as in patients who are on the floor, where the clinical exam is very specific. So in our case, in the ICU, many times the patient has a non-focal exam, and their only clinical finding for vasospasm is somnolence. And that could be from a multitude of etiologies. Not everybody who's somnolent in the ICU has vasospasm. So doing TCD on a daily basis is a great surveillance tool. It's non-invasive, it can be done at the bedside, and it has a 90% sensitivity. And then you can use it as a screening tool to determine who needs more aggressive imaging or therapies. So as we all know, delayed cerebral ischemia is our primary concern when we're talking about vasospasm. And most importantly on this slide is to look over here and to say that vasospasm occurs in about 50 to 70% of subarachnoid hemorrhage patients, and approximately half of those will have clinical complications of brain ischemia. So if you think about it, it's about 20% or 25% of people, and that's our job as the neurocritical care team, is the prevention and treatment of vasospasm. And so using as many tools as possible to make these determinations is quite valuable for us. So as we mentioned, it's safe, it's non-invasive, it's performed at the bedside, it's portable, and allows for dynamic monitoring of vasospasm. So there are head frames that can be used for continuous vasospasm monitoring. In contrast to angiography, TCD can predict symptomatic vasospasm, and that's because it's a physiologic test. So conventional cerebral angiography is not a physiologic test. It's an imaging test, but it doesn't tell you how much cerebral blood flow the brain is getting directly, because you can't measure the diastole and the systole components of angiography. We infer that based on our experiences and expertise by looking at the imaging that the patient is getting or appropriate or inappropriate cerebral blood flow. However, that's where the value of TCD is, because it's a physiologic test. The current levels of evidence for the use of TCD here from the American Heart Association and American Academy of Neurology, our own Neurocritical Care Society, tells us that it is safe and effective for daily monitoring of subarachnoid hemorrhage. However, lack of outcomes data is really the main limitation that has kept TCD from being part of standard of care. But recognize that the American Heart Association requires all comprehensive stroke centers to have TCD for subarachnoid hemorrhage monitoring. So the best literature on TCD is this review article from Gyan Kumar, who's currently at Mayo Clinic in Scottsdale, and his colleagues at the time at UAB did a very thorough meta-analysis. So you can see here highlighted below 2,870 patients, and TCD evidence of vasospasm was found to be highly predictive of DCI, sensitivity of 90%, specificity of 71%. I invite you to pull this article and to read it and to draw your own conclusions, but here I've highlighted some of the important aspects of it, namely that the sensitivity, and as we suggested, but the positive predictive value is 57%, the negative predictive value is 92%. And that's exactly what we need for a screening test. A screening test should not tell us that the patient has a normal test and they have severe vasospasm. However, a screening test should overcall cases such that it allows us to further investigate and make appropriate decisions. Here's an older meta-analysis from Liskowski and colleagues published several years ago now, which shows very similar data. What does our own Neurocritical Care Society say about this? It says that TCD is a good strategy for de-escalation of therapy and to determine what the consequences of reductions in mean arterial pressure are. At some point, we have to declare victory and send the patient out of the ICU. TCD is a good monitoring tool for that to determine when that is safe and effective. In addition, the consensus statement goes on to say the timing, the use, and how often TCD or other imaging studies are performed at risk during the at-risk period varies widely across the consensus group, and this is really the main challenge. because all of us in the profession practice differently based on biases that we have during our training and access to resources at our current center. And so you can see that at some centers, TCD is heavily accepted, and at others it's somewhat skeptical. And an institutional protocol that balances DCI with attempts to minimize radiation exposure is encouraged. I think we would all agree on that statement, that nobody wants to image the patient to the point that we're causing radiation harm, induced harm. So imaging of the vascular anatomy and or perfusion can be used to confirm the diagnosis of DCI in monitored good grade patients who show a change in neuroexam. So TCD can be used for that when you are looking for a clinical change. And here they suggest that what has been validated, which has the strongest support, is severe vasospasm, which will be represented by a mean flow velocity in excess of 200 centimeters per second in the anterior circulation with an associated what's called Lindegaard ratio, which is the measure of the mean flow velocity in the middle cerebral artery divided by the mean flow velocity in the extracranial ipsilateral intracranial artery, internal carotid artery. And so the reason that that Lindegaard ratio was created is that many times we use induced hypertension for our patients. And so if we increase the mean flow velocity in the middle cerebral artery, then the mean flow velocity will be elevated everywhere because we put the patient on vasopressor therapy. And therefore, if it's elevated here and elevated here, the ratio will cancel out. And therefore, it will tell us that that elevated mean flow velocity is not simply because of the Lindegaard ratio, not simply because of the patient being on vasopressors. However, if the patient indeed has severe vasospasm, that ratio will not be canceled out, and it will be elevated, indicating that the mean flow velocity in the middle cerebral artery is not proportionately elevated. It's astronomically elevated in comparison to that in the ipsilateral extracranial internal carotid artery. So the take-home messages are that vasospasm diagnosis on TCD can accurately predict DCI. There's high sensitivity and negative predictive value make TCD a good screening tool because of the low false negatives and a high probability that the patient with a normal TCD will truly have a low likelihood of developing DCI. Detection of TCD vasospasm can provide the opportunity to intervene using induced hypertension, inotropic agents, intra-arterial therapy, balloon angioplasty, and so on and so forth, as opposed to just simply waiting until the patient becomes symptomatic. What about the counterpoints? Not everybody is an adopter of TCD therapy. TCD-based therapies, I should say. So commonly somebody says that this is a tech-dependent study. So they say that the TCD showed high velocity, patient was taken for intervention, and the angiogram was normal. Well, indeed, that does happen, and that is the purpose of a screening test. The screening test should have false positives. Many times we have abnormalities on chest X-ray, and the patient is sent for a more comprehensive study, such as a CT of the chest, and that CT of the chest is normal. We encounter that on a daily basis. Therefore, we don't say that nobody should get a chest X-ray. If you want a more reliable test, you have to invest time and money to change and improve the quality of your lab by certifying your interpreters and sonographers, then pursuing accreditation. TCD does not change outcomes. There's a common statement that is made. So subarachnoid hemorrhage treatment is not standardized. In fact, you saw that directly stated within the Neurocritical Care Society consensus statement. If we were to poll the audience here of who's watching this program, and we said that the patient has a MCA, mean flow velocity, of 180 centimeters per second, we would get a variety of different answers as to what to do next, anywhere from do nothing to do a stat diagnostic cerebral angiogram. So therefore, until the treatment of subarachnoid hemorrhage is standardized, we cannot expect the test to change outcomes, as how we respond to the test results vary significantly from one practice to the next. What about other uses of TCD? Well, the Uniform Determination of Death Act, signed into law by President Reagan in 1981, defined the term brain death, which is described there. And many times we are unable to perform the complete clinical brain death exam. For example, the patient may be too unstable, not be able to tolerate the apnea test, so on and so forth. And at that time, we can look at doing ancillary tests. So TCD has a high level of support from the AAA guidelines. In fact, it has level A support, which is the same thing that it has for conventional cerebral angiography, which many of us do not obtain for confirmation or as an ancillary test for brain death. It has a higher level of evidence than the nuclear medicine uptake scans, which are commonly used in daily practice. And it certainly has a higher level of evidence than use of EEG or electroencephalography. So here's a patient that, here's a demonstration of a patient that progresses to brain death. What's important to understand is that there are patients who you don't have windows on, meaning you can't get an image, or their skull is too thick, or they have too much scalp edema from a trauma or something like that. So you have to be able to differentiate between the patient doesn't have windows, such as in elderly African Americans who have a higher propensity to have hyperostosis, or those on chronic dilantin therapy and so on and so forth, in comparison to the patient doesn't have cerebral blood flow. Therefore, you always need to establish a baseline study that shows that the patient has cerebral blood flow in all of the appropriate windows. And then as the patient progresses from, in this case, in this example, it is from anoxic brain injury, as they're building up the cerebral edema, you can see that the waveform morphology changes, and you ultimately get to a point where you're seeing reversal of flow in diastole, meaning in this image here, the heart contracts in systole, blood goes up to the brain, and because the ICP is so high in this given individual, the blood rapidly comes down and in fact refluxes back down outside of the skull, and then again it goes back up. And you get to the point as that process progresses that you end up getting something called small systolic spikes here, which means that blood flow is only going up to the brain during systole, and in between the two cardiac cycles, there is zero cerebral blood flow. And this is indicative of an ancillary test that supports the diagnosis of brain death when the clinical portion of the examination fits. So what about other uses of TCD? So PFO. So PFO diagnosis by TCD has, again, a higher level of evidence than transesophageal echocardiogram, which we commonly use. So here again, it's a non-invasive test that we can use. And what you do is that you inject agitated saline, and either the patient has a head frame on, or where you can monitor both MCAs, or in this example, the patient's probe, the probe is placed unilaterally on one of the MCAs, and this is what the embolus looks like. So you're actually monitoring the end organ, meaning the brain in this case, from which the emboli are going to. Now, the DAWN trial has had some significant implications in the neuro ICU. So many of us who take care of stroke patients as well in the ICU environment have seen a massive increase as our treatment window has opened. So So in the past, you would, again, if you're like our center, the neurointensivist is the one who makes the decision as to who comes and gets transferred from these satellite facilities or outlying community hospitals. And in the past, if they told us that the patient was last known well at 6 to 24 hours, you very rarely would transfer those patients, and you would tell them that they need to keep the patient there as we can't offer anything different. And as this has changed, now we're seeing more and more of these patients, and so I want to highlight here the use of TCD as a surveillance tool. So, for example, in this patient, they came in with an M1 thrombosis. They did not end up getting intervention, and so you have something that there's definitely a large vessel occlusion there, and you can see that the collateral blood flow there is quite reasonable, and here's the reconstruction. And so in a patient whose examination is stable, they had expressive aphasia and minimal right hemiparesis. They were started on off-label use of dual antiplatelet therapy. Now the patient's doing well, and you want to determine when is the appropriate time to get this patient out of the ICU. And so you send them for another CTA. It sort of shows the same ominous-looking imaging study. And so you've got a lot to lose by just simply saying that, well, the patient looks good, we'll send him to the floor and we'll see what happens. So this is where TCD can come in to make that determination more thoughtful. So here the left middle cerebral artery is highlighted in this panel, and you can see right off the bat in this image here, the mean flow velocity is 221 centimeters per second, which is consistent with a very, very severe stenosis. So that means this person has very little margin, a little bit of dehydration on the floor, or fever, or some other increase in metabolic demand, and the patient can complete that area of infarction. So the next day you monitor the patient, and you can see it's trending in the right direction. So the mean flow velocity is lower. It's still this is a very abnormal waveform. However, the mean flow velocity is getting lower, and that's telling you that your dual antiplatelet therapy is actually working to some degree. The following day, again, this is based on the assumption that the patient's clinical exam is unchanged, and in this case it was. The following day, you see that, well, this is starting to look like a normal-ish looking waveform, and the mean flow velocity is much, much less. So it's about 50% what you started with. And so being that it's day 7, being that the patient's clinical exam is unchanged, and being that you have this supportive evidence that that area of stenosis, or basically the clot, is actually starting to open up, you feel much more comfortable sending the patient out of the ICU. And that's where the role of TCD can help you in making an appropriate clinical decision. So I've listed some references here should you want to do some additional reading on these matters. And I thank you for your attention and time.